Dr. Jothydev is an endocrinologist working at Jothydev Diabetes Research Center in Trivandrum. He's the first author for Indian guidelines on vaccination, insulin pump, and glucose monitoring. He's a pioneer in cost-effective treatment of diabetes and use of telemedicine and technology. I don't think he really needs a lot of introduction. And I think Dr. Rahul would like to introduce the topic, and then we can hand over to Dr. Jothydev.
Okay, so Dr. Jothydev is going to speak on insulin use in India. Are we still a premix country? Over to you, Dr. Jothydev.
Thank you. Thank you, Dr. Anushree and Dr. Rakul. And congratulations and thanks again to my dear friend Manoj and Purvi. It's a very unique program and the title is very, very impressive. The theme is also very impressive.
Sir, I love the background and the frame.
All of you, please keep smiling. The photographs will be taken and it will be in the Kerala newspapers, courtesy Dr. Jothydev.
Manoj, let me ask you a question. What is the duration of my lecture so that I can plan accordingly?
20 minutes at least.
20 minutes. Okay, 20 minutes. So let me share my slides. Actually, I am in the middle of a live program here in television. So I'll be joining back to the channel at 8:05 or so. So thank you very much, Dr. Manoj and Puri. So Manoj has given me the task of discussing the use of insulin in India. And he has also told me that I should be including some cases in between. And I will start with a very typical case. And this is a case of type 1 diabetes, historically very important. I am pretty sure that you're familiar with Leonard Thompson. So we have been listening to Leonard Thompson during the entire month of January, because historically he is the boy who first received insulin. And on the right, we can see the records from the Toronto General Hospital. But what I am going to say, what I am going to discuss tonight is probably different from the usual discussions. Leonard Thompson was a public ward patient. He was admitted as a charity case. And at the time of admission, he was very emaciated. Skin and bones, ketosis, uncontrolled diabetes of more than 600 milligrams per deciliter. And he was given the first dose of injection on the 11th of January, 1922. If you ask me whether it was successful, of course, the glucose dropped, but the ketosis persisted. And he also developed abscess at the site of insulin injections. Collip went on purifying the pancreatic extract. He was restless and he was successful in another few days in developing an extract which is much more purified than the earlier one. And it was actually much more safer. And this new injection was given on the 23rd of January, 1922. And 23rd of January, 1922 is the day when the first successful insulin injection was delivered. And another injection was delivered the same day in the evening, which resulted in almost 77% reduction in the glucose. And within 24 hours, the boy, Leonard Thompson, looked better, brighter, and felt much stronger. So these are again the records from the same hospital, the Toronto General Hospital. The story continues. On the 15th of May, 1922, Leonard Thompson was discharged from the hospital. But unfortunately, that coincided with the insulin famine, which persisted then. Insulin was no longer available. So when he was discharged from the hospital, he was again back to the original starvation diet. That is the only treatment which was recommended before the discovery of insulin. So he left the hospital with no insulin. He continued with the starvation diet. He again was back to what he used to be in the earlier days, again back to skin and bones. But he was lucky to get readmitted in the same hospital in the October of the same year. And that time he was much more worse. He was in a severe acidosis. He was almost in a coma and he was severely dehydrated. But the boy survived. The boy survived. Later on, he joined a job. He could live up to the age of 27 years. How he died is still debatable, whether it was a pneumonia or it was due to a road traffic accident, nobody knows. The boy was diagnosed of type 1 diabetes and he was given an injection. He was given an injection at the age of 13 years and he survived with type 1 diabetes for another 13 years. So that is a story of the first injection and who received the first insulin, and that was Leonard Thompson. So let me now move on to some of the numbers, which are the stunning numbers, which we keep on discussing, which we keep on discussing with our colleagues, with our friends, and whenever we are lecturing, whenever we are discussing the necessity of insulinization in our patients, that more than half of those patients with diabetes, they are developing retinopathy, neuropathy, nephropathy. And 1/4 of our patients with diabetes, they develop chronic kidney disease. And according to you and me, chronic kidney disease is the most dreaded complication of diabetes, most dreaded complication of diabetes. And that is the costliest complication of diabetes. And these are all preventable, avoidable complications of diabetes. And we do have all the weapons with us. Still, we are losing the battle. Not even 20% are reaching the targets. More than 80 or 85 for all realistic reasons. It makes sense that 4 in 5 people with diabetes are uncontrolled. They are not reaching the targets of therapy. And even a layman, everyone knows the significance of reducing the glucose. If you are successful in reducing the hemoglobin A1C by 1%, you are reducing the chances of a lower extremity amputation by 43%. And we do have numbers. We do have numbers for all such complications. There is no dearth of evidence. We do have the comparative statistics with the available therapies, with the oral agents, with the injectables. Yes, insulin, which was discovered 100 years ago, is still the mainstay. It is still the treatment for diabetes, which has the maximal potential for lowering the hemoglobin A1C. And when you compare the different formulations available in our country, Premix, that is 30/70, which is a mixture of a long-acting and a rapid-acting or a short-acting insulin. These are the formulations where the glucose lowering is maximal when compared to any other insulin formulation. So these are a couple of beautiful girls from all across the country. So they come from north, east, west, south. So wherever they are located, wherever we are located, we can be from Delhi, from Punjab or Gujarat or from Mumbai or from Trivandrum, but 70% of energy intake in Indians, it comes from carbohydrate. And this is in contrast to 40% carb in the Caucasian population. So this is something which is true. And this is existing for many years. And of course, urbanization and the transformation in our culture, all of these could have added on to the existing hike in the carb intake. But this is the reality in our country. This is the reality which need to be considered. This very high intake of carb need to be considered whenever a responsible physician is making a prescription of insulin to our patients. More than 50%. So when you are considering 24 hours in a day, more than 50% of which is spent in the postprandial state means when you are ordering a prescription, the prescription should be addressing not only the fasting, not only the preprandial, but postprandial is a major component. Major component because more than 50% contribution in India comes from postprandial. And that is a true Asian picture. Of course, I know that this is going to be a repetition for many of you. The Monier et al., the studies we have been discussing for the past more than 10 years. But remember, even when the glucose is controlled, or even when the glucose is very high at an A1C of 12%, when we say that fasting needs to be addressed first when the glucose is uncontrolled, still look at the contribution from the postprandial. And that is the blue-colored bars over there. The blue-colored bars are significant, irrespective of the glucose levels. So across all the levels of hemoglobin A1C depicted in the picture over there, the cartoon over there, whatever be the hemoglobin A1C, there is a substantial contribution in the Indian patient. This is in contrast to the Caucasian. The South Asians, in contrast to the Monier data in the Caucasian population, the contribution from the postprandial remains significant. That is probably one reason in a prospective validation survey, the physicians have made a remark when they were asked the preferred insulin when the oral agents fail in India. More than 61% responded that it will be Idagas, that is Rizodac. That is the preferred insulin to be initiated as well as to be intensified in the Indian scenario. Let me now move on to the second history. And this is again a real life story. So I have begun with the story of a type 1, and this is my own patient. And this happens to be a modern medicine doctor who consulted me long ago, 11 years ago, when the patient was 55 years old. Yes, he was 55 years old. And he was at that time having a type 2 diabetes of 6 years duration on metformin and glibenclamide with a hemoglobin A1C of 10.5%. I spent 1 hour with him. I still remember. I have spent 1 hour with, because I knew him for many years, very senior. I spent 1 hour with him and I explained about what diabetes is, what are the implications of diabetes, what is the importance of preventing complications, because all the lab parameters were normal except for the high hemoglobin A1C. And we gave a prescription of the best available premix insulin, gliptin, metformin, and I added statins and ARBs. And he appeared to be happy, but I found that he was not that convinced. So I asked my diabetes educator, dietitian, and the nurse, and they spent another 1.5 hours with him on how to monitor the glucose, on how to report via telemedicine. We offered free telemedicine follow-up twice a week. And we tried contacting him after we left. Many times we tried contacting him. There was no response. I remember talking to him 2 or 3 times later on, and he was telling me that he is extremely busy and he cannot start insulin. And when repeatedly asking, he said that he is still afraid of hypoglycemia, which is so common with insulin. Why I am presenting this case today? Because I happened to see him last week. And that was on the 14th of January, 2022. After a long, I couldn't even recognize him. I very politely, I asked him, what made you come back, dear sir? And he said, you have told me to start glucose monitoring. You told me to start insulin 11 years ago. I have started insulin recently, but I have started glucose monitoring 4 days ago. And I found that my average glucose is above 250 milligrams per deciliter. So please help me, Jyoti. And in questioning, he told me that he had 2 episodes of an MI, bilateral retinopathy with diminished vision. He has got loss of sensations, both extremities, pedal edema. And for the last 2 months, he was started on dialysis 3 times a week. And this is the story. This is the real story, not of an ordinary layman. This is a story of a modern medicine doctor. So this is happening everywhere to everyone, independent of whether they are educated or not. And similar episodes, I am pretty sure it's happening to all of you. It happens every day in our clinical practice. And hence the message is very simple. Dr. Manoj Chawla, our Dr. Vasantakumar Sari is here, the president of RSSBI, Dr. Benshi Sabu is here. So all these stalwarts, all of you should continue. Dr. Manoj and the team, you should continue organizing, continuing medical education programs. And that is required. That is required for doctors from all across the specialties, since everyone is practicing, everyone is providing prescriptions for our patients with diabetes. And this is a time when we are having safe medications like Idagas. This is a paper that we have presented at the American Diabetes Association. Dr. Benji is also a co-author, where we have shown in the real world IJDT not only improves hemoglobin A1C, but it is also an insulin formulation with minimal hypoglycemia. Remember, the doctor was afraid of hypoglycemia. For more than 5 years, formulations such as IJDT is available in our country with minimal hypoglycemia. 92% of the patients achieving customized hemoglobin A1C targets, and with none of them developing an episode of a severe hypoglycemia. Another study evaluating the prescription pattern and the clinical outcomes, and this is in 291 patients where we have shown. Look at the baseline data. The patients on oral agents, patients previously on insulin plus oral agents, and across all the categories, there is a significant improvement in the hemoglobin A1C. So this is a 2-in-1 solution. And this is a solution which is most suited for the Indian scenario. And IJDT is the prudent choice for both once daily and for twice daily premix insulinization. And RSSDI ESC guidelines have also recommended the use of IJDT in those patients who are failing on existing therapies. And when you compare with a basal insulin such as glargine, what do you mean by total diabetes control? There is a superior hemoglobin A1C reduction, 1.4% with IJDT. There is a superior reduction in the postprandial. But my recommendation is this insulin needs to be recommended because apart from efficacy, there is a significantly lower chances of hypoglycemia. In a recent multinational study, this is a rise. India was also part of this study where you can see the A1C reduction in the Indian subgroup, very substantial, a robust reduction across all the countries with the rise reduction. But I am more interested in this data on the resource utilization. What about the resource utilization? The resource utilization is related to the episodes of hypoglycemia. The resource utilization reduction of 61% with rise reduction when compared to the baseline therapy. And this is with self-reported outpatient visits to the hospital. What about self-reported work days which are missed? Very, very pertinent in the Indian scenario. The work days which are lost, 90% reduction with IJDT. So it is a cost-effective solution where you have safety, efficacy, and also reduction in the overall burden and cost. A very recent study published in the December of 2021. And this is a landmark SMART study from over 40 centers. So this is a multicentric study from across the country, a prospective single-arm observational study. More than 1,000 patients were included in the study. And the hemoglobin A1C reduction, look at the hemoglobin A1C reduction, it is almost 2% from 9.5%. So the baseline of 9.5%. And at the end of 12 months, 7.7%. There again, there were no episodes of any serious symptomatic hypoglycemia. So now the question for all of you listening to us, the doctors and the healthcare professionals, where do you start? How do you start? When do you start? Whom do you start? We can start Ryzodec or IJDT in those patients with diabetes uncontrolled on current drugs. And this can be 2 or 3 oral agents. Don't wait. Don't wait by adding more oral agents. That is a crime. You should immediately start them on insulin. Patients who are currently uncontrolled on either a basal insulin or other premix insulins or multiple daily injections. And the patient type is also very important. Apart from above the age of 18 years, elderly, the PK/PD properties of this insulin, though there are 2 components, an ultra long-acting degludec, which is a unique insulin with lower chances of hypoglycemia. When compared to glargine, the nocturnal hypoglycemia is reduced by more than 52% in the devout clinical trial. So in the elderly, it is a preferred formulation. And in the presence of renal and hepatic impairment. In the presence of renal and hepatic impairment, when the PKPD properties are retained, and in the presence of multiple complications or comorbidities in diabetes, this is the insulin of choice. But if you ask me, and this is my personalized answer, Rysodec or Idegast is the insulin of choice for all of us dear and near to us, our close relatives and friends, the doctor colleagues. This is the safest, most latest, and the best insulin of choice in India. And if you have any question on titration, it is easy to titrate. Our Manoj Chawla is there, and he is co-authoring this consensus on insulin dose and titration algorithm, and he will answer to your questions. It is very easy to titrate the dose. You go by the pre-dinner and you can go by the fasting. But remember, once in a while, please measure the postprandial glucose as well. So we have been discussing about the evolution of insulin. And in the previous talk, Sanjay was discussing about the evolution of insulin delivery devices. In India, we are very, very fortunate to have the old, very old, and the new, and even the newest formulations and devices. And please remember, for the eligible patients, for the affordable and eligible patients, provide them the best formulation which is available. In a country where there is a high carb diet resulting in significantly high PPG levels, Idegast is the choice as an insulin for initiation and for intensification. And this is the insulin which is going to offer a total protection. And this is my last slide, reminding all my colleagues and friends that IJDT, the International Journal of Diabetes and Technology, published by Walters Kluwer, the submission site is open, and you can definitely submit your original research reviews and case reports. So thank you again, Dr. Manoj, Purvi, and the team for giving me this opportunity and for the patient listening.